You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for November 18th, 2022. This week, more AHA review, including IRONMAN, ECMO-CS, CTS-AMI, and progressive AFib trials. First, 3 brief announcements. First, I want to say a hearty thank you to our listeners. TWIC is up to 543 ratings on Apple Podcasts. I know there are oodles of podcasts, so I'm grateful for your support. And remember, take a second and give us a rating or write us a brief review on any app that you use. Second, I had some great feedback this week. On Twitter, Dr. Andre Zimmerman, a research fellow in the TIMI study group, pushed back on my comment last week about triglycerides being a marker of risk but not a causal factor. Now, he cited genetic data supporting triglyceride-rich lipoproteins as causal and noted that lowering triglycerides may not be enough. He argued that the PEMA-Fibrate trial may not have reduced CV events because it did not reduce both triglycerides and ApoB. In fact, in the active arm of Prominent trial, ApoB increased slightly. I'll link in the show notes to his tweet thread. It's quite good. Thank you, Andre, and please, friends, keep it up. If you disagree with me, let me know. Third announcement, next week is Thanksgiving, and TWIC podcast takes a break and returns on Friday, December 2nd. Thanksgiving for the Mandrolas means lots of family time. I'll be crushing the trainer bike on Zwift, and I'm reading. I'm finishing The Gentleman in Moscow, and will plan The Managerial Revolution by John Burnham next. All right, first topic is the IRONMAN trial. Now, we start with the IRONMAN trial, not because it has to be the best trial acronym I've seen in years, but because it has both elements of direct clinical concern and because it provides a major lesson in trial interpretation. All right, first the clinical, then the critical appraisal issues. I wrote a column on IRONMAN, and it's up on theheart.org, Medscape Cardiology. Go take a look at it. Clinically, nearly half of patients with heart failure with reduced ejection fraction have low iron levels, and students learned very early on that humans require iron to make hemoglobin, which transport oxygen to the tissues. So come on. Common sense holds that if iron is low, replacing it has to help. The IRONMAN trial addressed these exact questions. This was an RCT conducted in the UK NHS system, and it used a novel iron replacement compound called ferric derosmaltose. Iron-deficient patients with heart failure with reduced ejection fraction and an EF less than 45% were randomly assigned to intravenous iron infusions or usual care. Now, these were mostly outpatients. The trialists aimed to do repeat infusions with the goal being long-term maintenance of adequate iron levels. The primary endpoint was cardiovascular death or recurrent heart failure admissions, and the results, slightly more than 1,100 patients were enrolled over 5 years. And over 3 years, the primary outcome was reduced by 18% in the iron group compared with the usual care group. Now, this nearly made statistical significance. The rate ratio was 0.82, right? That's the 18% reduction. And the confidence intervals went from 0.66 to 1.02 with a p-value of 0.07. Now, hospitalizations for heart failure drove the reduction of the primary endpoint. CV death, all-cause mortality, total hospitalizations did not differ significantly. By 20 months, quality of life scores also did not differ significantly between the two treatment groups, which was remarkable because this was an open-label trial. Now, serious adverse events also did not differ. The authors did a sensitivity analysis in which they excluded the pandemic time. The good news was that only 9% of patients were affected by lockdowns, and this analysis of slightly fewer patients found a 24% reduction in the primary endpoint that barely met statistical significance. But this was again driven by lower hospitalizations for heart failure with no significant reductions in CV death or all-cause death. All right, I have three main comments. First, what about that 18% reduction in the primary with a p-value of 0.07? Was IRONMAN positive or negative trial? Well, technically, the upper bound of the 95% confidence interval went to 1.02, and anything 1 or greater means no effect. And the p-value, which is a measure of how surprising the data are given the made-up hypothesis of no difference in the treatment arms, or null hypothesis, did not meet our accepted and probably lenient standard of 0.05. So, no, IRONMAN must be considered a trial with a non-significant primary endpoint. Notice I did not say negative. I think we should jettison that binary distinction of negative and positive. Consider that in IRONMAN, the lower bound of the 95% confidence interval also included the possibility of a 34% reduction in the primary endpoint. And if you consider the totality of the confidence interval of the primary endpoint, right, it ranges from 0.66 to 1.02, and you imagine sort of a bell curve between those two, the probability of some benefit seems more likely than not. But the next question is always, okay, if there's some benefit, was it clinically meaningful? And as an aside, that's always what we do with trials, right? We first decide, was the result signal or noise? That requires looking at the confidence intervals and some measure of probability like a p-value or posterior probability in a Bayesian analysis. But the next issue is always, was the effect size clinically meaningful? In IRONMAN, the modestly lower rate of the primary endpoint was driven by heart failure hospitalizations. More important endpoints like CV death, all-cause hospitalizations, or even quality of life were not different. And everybody knows, heart failure with reduced ejection fraction is not a benign condition. You'd want a therapy, especially one that requires patients to come to an infusion center, give up hours of their day to move something more than one type of hospitalization. Again, that matter of heart failure hospitalization comes up. Who cares about a reduction in heart failure hospitalizations if it's not enough to reduce total hospital admissions? Which brings me to the third point. Are iron infusions worth the trouble given these results? Patients with heart failure incur a significant burden. They have to take bunches of pills. They have to make doctor's appointments. They have to pay attention to their diet, daily weights. So adding another really significant burden of iron infusions is not a small thing. As clinicians, right, we go to meetings, we hear about all the great therapies for heart failure, and they surely are. But we must never forget that there is more to life than being a patient. We must let our patients have time to live life. What's more, IRONMAN enrolled relatively young 73-year-old patients who were well enough to be enrolled in a trial. Many patients with heart failure have significant comorbid conditions that would have prohibited that, things like arthritis, balance issues, dementia, and many patients with heart failure don't have the family support required to get to infusion centers. Therefore, I think before adding and paying for outpatient visits for infusion therapy, you'd want a more meaningful effect size and more statistically robust result. The weakness of this IRONMAN data also informs payers. Again, in a system where cost is no issue, sure, go ahead, offer an iron infusions, but this includes exactly 0 health systems. I know this is a challenging area. Let me know what you think. All right, second trial, ECMO-CS. Now, you don't have to be in cardiology long to realize how bad cardiogenic shock is. And I'm going to say something that sounds a bit goofy, but cardiogenic shock makes you realize the importance of that pump in our chest. Sometimes I just listen to it at night with a stethoscope. The heart is so darn reliable. 100,000 heartbeats a day for years on years. We just forget about it. Then, When it fails to send enough blood, things go south quickly. Patients turn gray, organs shut down, the brain stops working, and death is imminent. You hope upon hope that for patients who have a correctable cause of cardiogenic shock, that aggressive support can see the patient through that time of reduced cardiac flow. So support should work in some patients. But of course, the only way to sort out if things work in medicine is with an RCT. And few forms of support are more aggressive than veno-arterial extracorporeal membrane oxygenation, or ECMO. Now, I did not know that VA ECMO was increasing in use, but apparently it is. My partner tells me that hospital reimbursement for VA ECMO is generous, and I'm sure that has nothing to do with anything. At AHA, thanks to investigators from the Czech Republic, first author Peter Ostadal, we have results of an RCT comparing immediate VA ECMO to an initially conservative strategy in patients with cardiogenic shock. First, a brief note on VA ECMO, which will be an oversimplification. VA ECMO is when blood is removed from the veins, preload reduction. It's then sent to an oxygenator outside the body and pumped back into the arterial system, usually in the femoral artery. And that's right, oxygenated blood is pumped backwards or retrograde back up the aorta, and then it mixes with blood coming out of the heart at some point. Now, I spoke with our ECMO person at our hospital and read up on this topic, and what I have learned is that VA ECMO is akin to a super complex symphony. You have to monitor many, many parameters and adjust these flows accordingly, and this requires serious human expertise. Just recall for a second that blood pumped back into the aorta is an increase in afterload for a failing pump. I'm going to link to a review in the show notes by Raw et al., RAO, in Circ Heart Failure from 2018. It's an excellent review. Now, the journal Circulation published the ECMO-CS trial presented at AHA. This had 122 patients randomized at 4 centers. Most patients had cardiogenic shock due to a complication of MI, but a fifth had decompensation of chronic heart failure. Their primary endpoint was a composite of death, circulatory arrest, and an implant of another mechanical circulatory support at 30 days. Now, before I tell you the results, it's important to set out that ECMO-CS trial was not an ECMO versus no ECMO trial. Instead, it was an immediate ECMO versus initial conservative therapy with ECMO if needed. And in fact, 23 patients, nearly 40% of the control arm, eventually got downstream ECMO. The primary endpoint occurred in 64 patients in the ECMO group, 71% of the initial conservative strategy group for hazard ratio of 0.72, but that 28% reduction had 95% confidence intervals that range from 0.46 to 1.12, and the p-value was 0.21, and that's a strongly non-significant endpoint. Though you could argue that the confidence intervals were wide, allowing for more than a 50% lower rate and 12% higher rate of the endpoint. But the two main components of that endpoint, death and resuscitated cardiac arrest, showed no differences. All-cause death was 50 versus 47%, and cardiac arrest was 10.3 versus 14%. Serious adverse events such as sepsis, pneumonia, stroke, leg ischemia, and bleeding were not different in the two groups. These results places this trial in line with other cardiogenic shock support trials. A smaller VA ECMO study also failed to show benefit over medical therapy, and the large intra-aortic balloon pump SHOCK 2 trial found no benefit of the balloon pump versus conservative care. Good news is there's 4 ongoing trials in this space. ECLS shock and EuroShock trials are going to compare VA ECMO and conservative therapy. The Anchor trial is going to compare VA ECMO plus balloon pump and conservative therapy. And of course, the Danger Shock trial will compare the Impella support device to conservative therapy. Now, I want to say something I don't normally say regarding trials. What ECMO-CS and other trials in this space show us is that on average, there's not a benefit from support. But another one of my interventional cardiology colleagues told me something that stuck with me. He said, "John, I know what the average results are, but I can tell you there are occasional patients who we would not get out of the cath lab without support." And I believe him. And what that tells me is that while it would be unwise to routinely use these devices, it might also be unwise to not have support available for any patient. Of course, this is where I usually add the caveat that the onus is on proponents to find a population in whom the therapy works. But I also admit that this might be very hard to do in a disease like cardiogenic shock. And finally, sadly, and I wished I didn't need to say this, is that I wonder whether generous reimbursement for some forms of support may influence decision-making. Okay, third topic is the CTS-AMI trial. Buckle up for this one. A few facts before I tell you about the trial, which studied an intervention to reduce heart outcomes after a STEMI and was presented as a late-breaking clinical trial at one of the world's biggest cardiology conferences, the AHA. And we all know that patients with STEMI, especially those who present a bit late, still face high in-hospital mortality, myocardial no-flow, and reperfusion injury. And there are no drugs available that have proven beneficial in this space. I'm going to tell you the results of the CTS-AMI trial first. Okay, 30-day MACE was reduced by a highly significant 36%, 3.4% versus 5.2% in absolute terms. And among the primary endpoint components, cardiac death was reduced by 30%, reinfarction reduced by 65%, and the benefit of this intervention was similar across every subgroup. And at 1 year, the MACE results also held up. The primary endpoint, CV death, reinfarction, and stroke, all significantly lower in the active arm. Now let me tell you that the CTS-AMI randomized nearly 3,800 patients from 124 hospitals. An important feature of these patients was that many had delayed presentation of their STEMI. The symptom to balloon time was 5.7 hours. Now just pause there, think for a second, and ponder these results. Huge reductions in MACE, CV death, reinfarction in a large multi-center trial presented in a marquee congress. What's the intervention? Surely it is set for FDA approval. It's a Chinese medicine compound made of insects and herbs called tongxinlo. Tongxinlo. Really, it is. Traditionally, tongxinlo has been thought to have clinical benefits for patients with angina, including a reduction of the occurrence of AMI and complications of some types of heart surgery. And there's even a 2006 Cochrane review which found some evidence that it helps patients with unstable angina, though all the trials in that review had methodologic limitations. Now, at AHA, trial discussant Ken Mahaffey was surprised. He said something like, "We need more details about the analysis, trial conduct, and the potential mechanisms." There were calls at AHA from others to see this trial repeated in a Western population. And there were calls to see the angiograms, echoes, and biomarkers in the trial. In other words, people wanted to see the source data. Now, while I agree it's always good to see confirmatory trials, and of course the published paper, the disbelief here kind of sort of got me thinking about standard judging of science. Again, this was not a poster from a trainee. This was a major clinical trial with hard endpoint reduction presented at a marquee session at AHA. We don't understand Chinese medicine or this compound, which had herbs and insects. So boom, we're skeptical. And that's good, right? Skepticism is a core tenet of the TWIC podcast. I mean, Carl Sagan himself said skepticism is science. But, calls to see source data make me smile. Okay, if this is your position, let's sit down with an espresso and go through the last few years of New England papers and look at the data sharing statements which are attached to every trial. Most of them, especially those from industry, will say, no, you don't get to see the source data. Trust us. Now, few are skeptical of these data. Now, I don't know if CTS-AMI replicates, but boy, if it does, we all are going to learn a bunch. There are a lot of late presentation MIs, and I think we ought to be randomizing them to tongxinlo or placebo quite soon. Okay, final topic today is AFib and ablation. Jason Andrade presented results of a study called Progressive AFib at AHA. The New England Journal published it, but it did not allow the acronym. Now, presumably, this is because this was a 3-year follow-up data from their early AF study, which was published in January of 2021. And briefly, early AF randomized 300 patients with symptomatic paroxysmal AFib who had not received rhythm control therapy to either cryoballoon, PVI, or antiarrhythmic drugs. All patients in that trial had a loop recorder, ILR, and the primary endpoint was first documented AFib. Now, patients had to have AFib in the previous 2 years, and drug therapy was standardized with very fair doses of drugs used. These were young patients at age 57, and early AF was really a well-conducted trial. And at the 1-year results of early AF, which was published in 2021, found that cryoballoon ablation resulted in a 52% relative risk reduction in the first occurrence of AFib. Though, again, the recurrence rates were very high in both groups. There was 43% of patients had recurrence in the cryoballoon arm versus 68% with drugs. The loop recorder allowed the authors to calculate AF burden, and here the median AF burden in the cryoballoon arm was actually 0, but it was only 0.13% in the antiarrhythmic drug arm. This was statistically significant, but the point was that these patients all had low burden AF. Now, at AHA, in the progressive AFib study follow-up at 36 months, the authors looked at a different endpoint. Here, it was the conversion of paroxysmal AFib to persistent AFib. Cryoballoon, compared to antiarrhythmic drugs, reduced the presence of persistent AFib by 75%. But again, my friends, the absolute numbers were small. 3 patients in the cryoballoon arm had persistent AFib and 11 in the antiarrhythmic drug arm. And of course, the AF burden results at 3 years were similar to the early AF 1-year results. At 3 years, there was very, very low AF burden in the cryoballoon arm and very low AF burden with antiarrhythmic drugs, as these were all low-burden young AFib patients. Now, at 3 years, 8 patients, or 5.2% in the ablation group versus 25 patients, or 16.8%, in the drug arm had been hospitalized, and that was a relative risk reduction of nearly 70%. Complication rates were low in both arms, but there was a cardiac tamponade in a patient who received ablation, and 3 patients had transient phrenic nerve injury that resolved in 3 months, obviously in the cryoballoon arm. Now, my comments. I respect Jason Andrade and many of the Canadian investigators in this trial. I love it that so many RCTs in the field of EP come from this group and other Canadian investigators. And I have no doubt that ablation suppresses AFib episodes recorded on a monitor a bit better than drugs. I have no qualms with the internal validity or trial conduct. What I have trouble with here is that AF ablation versus drug trials are not advancing the field. Okay, the authors write in their discussion, quote, catheter ablation is a tailored procedure that is designed to modify the pathogenic mechanism of AFib initiation and perpetuation by means of a combination of PVI, neuromodulation, or substrate modification. Now, they don't give any references. Why? Because it's speculation. In fact, all of AFib pathogenesis and AFib ablation is speculation, and that is the problem. When we ablate an accessory pathway to cure SVT, we understand the mechanism. When we ablate a channel of slow conduction in a post-MI scar to vanquish VT, we understand the mechanism. With AFib, there is no understanding of causal mechanisms. I mean, patients ask me all the time, how do you know where to burn? And the answer is, we really don't. Studies show that while inadequate PV isolation increases the odds of AFib recurrence, it is well known that many patients who have incomplete pulmonary vein isolation don't get recurrent AFib. Now, another issue with ablation versus drug trials, especially as young people with low burden AFib, is a lack of a proper control arm. My friend Soren Diedrichsen and a fellow loop study authors have elegantly shown that patients with low burden AFib often have spontaneous resolution of AFib, and I'll cite his paper in JACC in the show notes. I had AFib for a year, a lot of it, and it just stopped. Now, had I had an ablation, it would be considered as a success. And I really want everyone to think about the choice of AFib episodes recorded on a monitor as an endpoint. Now, that is surely not a meaningless endpoint, but is still a surrogate endpoint. Future trials need a non-ablation, non-drug arm, perhaps with a multidisciplinary team managing that arm. Now, this team would say to a patient with AFib, yes, you had a few hours of AFib. It's okay. Keep taking your anticoagulant, lose weight, reduce alcohol, use your CPAP, and live your life. If things worsen, we have plenty of choices of therapy. We're your friends. We're here with you. These trials also need to have a proper sham control arm. You put catheters in and don't ablate. Let's see what happens. Medicine is replete with examples that shocked us with the sham or placebo controls. If PCI of a proximal LAD lesion doesn't reduce angina or exercise time over a sham, we surely need to study this with PVI. Now, another problem I have with studies like this is 100% not the author's issue, but it's on us as a field. Okay, EP doctors love to do procedures. We get paid to do procedures, and studies like this foster that urge. Medtronic sells more cryoballoons. Hospitals make tons of money on AF ablation. And in the U.S., right now, EP doctors are facing substantial cuts in reimbursement for AFib ablation. Now, what do you think this will do to the urge to ablate AFib? Do you think EP docs will say, no worries, I'm fine with 30% less pay? Or do you think some will find more patients to ablate? I'm asking. My approach to patients with AFib remains the same. Remove fear, educate, treat risk factors, give peace a chance to heal. Sometimes use antiarrhythmic drugs, always for the short term to allow time to reverse risk factors, and use ablation when patients remain symptomatic and are well versed in the potential risks. So that's it for this week in cardiology. I went a little longer. Next week is Thanksgiving. I'll have more from AHA and other stories in 2 weeks. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, give us a rating, write us a brief review. These things help others find us. Until 2 weeks, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.